Hi, everyone. I think we'll get started. Can you hear me okay? Seems like yes. Hi. Welcome to UVA Medical Center Hour. My name is Margaret Hayden. I'm a primary care doctor and director of the Medical Center Hour this academic year, which is a program of UVA Center for Health, Humanities, and Ethics. Today, we are partnering with the UVA Center for Excellence in Education to bring you both the combined Medical Center Hour and Education Grand Rounds. A couple quick logistical details. One, we are in person and on Zoom today. There'll be an opportunity for question and answers after the talk. For those of you in the room, raise your hands. We'll have someone running with a mic, and then I'll monitor the Q&A on Zoom and ask questions if there's time for that. And then for those of you who come to Medical Center Hour, the CME is a little bit different today. Instead of doing a code, there's a sign-in sheet in person, and we'll get a list of the attendees on Zoom and give credit that way. I'm now going to turn things over to Dr. Mike Ryan, who's going to introduce our speaker and give a little bit more intro.
All right, thanks for joining us. So I'm Mike Ryan, the director of the Center for Excellence in Education, and I'm going to introduce our speaker in just a moment, but I'm also going to take the opportunity to highlight the coming events through our center, since this is our sort of kickoff to the 2025-2026 academic year. So Dr. Bynum, who I'll introduce in a moment, is our first Education Grand Round Speaker of the Year. We will have 4 in conjunction with the Brody Committee and then also our own independent speakers coming up. So we have 3 of those identified right now, and I'll just share with you the dates and who they are. So Dr. Bynum is, of course, coming to us today. And then we will have our Brody Scholar coming the week of November 9th. That's Rena Karani. She's coming down from New York City, and her talk is going to be about assessment in medical education. And then we've also confirmed our keynote speaker for Innovation in Education Week, which I'll talk more about in a minute. That's going to be Barrett Fromey from the University of Chicago, who's going to talk about the master adaptive teacher and how to adapt your teaching to the changing environment. And then we'll have one more Grand Round speaker late spring that will be to be announced. Other key events, so as I mentioned, Dr. Fromey is going to be doing our keynote for Innovation in Education Week. For those unfamiliar, that is an entire week devoted towards medical education, scholarship, innovation, all those sorts of things. And so she will have both a workshop and a keynote the week of March 9th. We will also have several different presentations, including original research from all of you, trainees, with a reception that will come that week as well. There is a call for abstracts that will go live in December, so keep notice of your emails coming up, and then we'll have notifications in January for those who are presenting. Other events, we're going to also kick off our monthly journal club in 2 weeks. So our first one will be led by Dr. Bradley on October 7th, and then we'll have one every month after that. And there's many other events to stay tuned for. So thank you guys for coming to this session. We're very excited about it, and I hope you'll join us for the other events. So now I will turn to our presenter today, Professor Doctor, is that what the MD PhD thing? So Dr. Bynum is both an MD and a PhD. He comes to us from Duke University, where he is an associate professor of family medicine. He's also a veteran of the United States Air Force. He received his MD from the University of South Carolina in 2010, completed his residency in family medicine with the US Air Force, and his PhD through the Maastricht University in the Netherlands, where he defended his thesis, which is highly related to what he's talking about today. It was entitled Out of the Shadows, a Qualitative Exploration of Shame in Medical Learners, which was also awarded the best doctoral dissertation by the Association of Medical Education in Europe. He's also co-founder and co-director of the Shame Lab, which conducts research, develops training, and delivers consultancy to advance constructive engagement with shame in professional practice. So we are very honored to have Dr. Bynum come talk with us today, and I hope you guys will give him a warm welcome.
Thank you, Mike. Gosh, thank you for such a just awesome, warm reception so far. I've gotten the privilege of spending time yesterday, this morning, with folks from your community, talking about this topic, learning about what you're doing, where it might be applicable, and I do a lot of rounding and moving around different institutions, and I can really tell when there's a place that's ready for this, ready to implement it, already implementing a lot of the values and principles we'll talk about, and this is absolutely a place like that. This is just such a great, warm, innovative, progressive environment. And so I really hope that this lands in a way that's meaningful for you. This vertical room, I have to say, I also just love the different places I get to present. It reminds me of being at Duke. There's this, if anybody's ever been to Duke, there's an extremely vertical lecture hall in the main hospital. And I was doing my first grand rounds for surgery there. And it was like this, steeper, darker, and everybody was in a white coat. And then on the wall behind me, they were doing that CME thing where you text a code. The code was shame, and it was big block letters, and it was red. It was in red. And I was sitting up there, you know, a little insecure and thinking, God, I don't know how this is going to go, but it feels important. And you know, it is important. It's actually super important that we be able to talk about these fundamental human experiences, which are part and parcel of the work we're doing, the people we are, and the way we do that work and feel about ourselves. And so well, actually, I don't have a disclosure with an excluded entity. It took me 13 years to get a disclosure. It's just that we sometimes do consulting type work with this. We help develop training. I get paid honoraria sometimes for this work. So I do get paid through my academic work on shame. And, you know, I'm happy about that. It's, you know, turns out that helps with sustainability. I'm certainly not here to sell you on shame, other than I think it's really important and we need to be talking about it. I want to give a critical acknowledgement here, and you're going to understand why as you go through this talk. This is Hannah Mumby, and she's now just kind of become a beloved member of our team. She's essentially our in-house artist. So we do a lot of work with creative folks trying to bring new ways of engaging with this topic. And Hannah has done a lot of work with us over many years, and now to the point where we can almost fill an entire presentation with work from her that supports what we're doing. And she's so incredibly talented that I have to foreground the work she's done for us and invite you to check out her website. She's amazing. So in working with this topic, we work a lot with metaphor. And so I'm gonna flog you with metaphors over the course of this talk. It's in many ways the way I come to understand these types of experiences as well as my own. And one of the ones we've worked with at times is the metaphor of fire. So understanding that this emotion of shame can be an emotional reaction that can be sparked by certain events, can be exacerbated by certain factors, can cause significant impact and change in the substrate that's affecting it, and that can be modified and worked with and harnessed, but never extinguished, I'm going to argue, as we engage with this more openly. So building on this, I'm a massive proponent. In fact, if you take nothing else away from this talk, of the importance of finding ways to talk about this emotion and the experiences that come with it. Like, that is the number one thing where I'm here to do, is to try and help make this a part of our working vocabulary as professionals, okay, and as people in the world. So I'm certainly going to tell you about my own story, because I can't ask you to do that without telling you my own. It also answers the question that most people have, which is, how did you become the shame guy in medicine? Which I've been called too many times now to admit. And while it's a weird term for me, I never set out to be a shame guy. I mean, this was totally off my radar until I fell painfully into it. And it happened at a time when I was early in my residency training in family medicine, early second year, increasing responsibility, somewhat static skill, or slow to catch up skill. And the long and the short of it is, and if you go on the internet, you can hear all the different ways I've told this story. So I'm going to just tell you the abridged version. But I was coming off a 24-hour shift, and a patient came in having a placental abruption. It's an obstetric emergency. Before I knew it, I mean, I was sort of whisked in the room by the obstetrician on call. Found myself in the middle of chaos, of course, and a baby who was actively dying, heart rate in the 80s, sustained and going down, and an active hemorrhage, and a crowning head, which meant that a vacuum-assisted delivery was possible. Okay, and thank God I didn't have to make that decision at the time. The obstetrician made that one, and that's never an easy decision to make. It was the obvious decision, I think, in this case. But what I did have to do was deliver the baby via the vacuum device. And almost like this was just kind of happening to me. I was just sort of in the situation and then doing it. Delivered the baby. Thank God, the baby did okay. I mean, I don't know where this would have all led had something bad happened to the baby. I like to think still to this moment, but it didn't work out for the mom. So I caused a really bad maternal injury in the course of this delivery. And it wasn't a vaginal laceration that can happen, with a vaginal childbirth, especially one with a vacuum. It was significantly worse than what would be expected. And it was an experience where, I mean, you just live in fear of this moment as a clinician, as a person who's just striving to do good things well all the time, whether that's in medicine or elsewhere, where you and everybody else knows, and this is how it was, that something just went wrong. Okay, and that was the spark. I mean, that was the catalyst. Now, I was in an environment of high combustibility, you could say. This was an environment where there was static in the air and it was ready for a spark. Wasn't a terribly friendly unit, not a lot of vulnerability. People didn't really treat each other terribly well. I was pretty insecure as a new learner in this space, out of my comfort zone. The setup was there, and then there was the match strike. And if you watched me in the way that I responded to this, you would have seen a guy who just did a delivery, had something go really wrong, an obstetrician that stepped in. You probably would have noticed, but not thought much of it, that I slipped out of the room. In my state in that moment, there was so much panic and fight or flight and anxiety. And as one of our participants said once, guts fell out on the floor, heat rising up, all the overwhelming urge is just to hide and disappear. I mean, literally, and it's primitive. And that primitive urge took me, once the obstetrician had taken over and things were safe, out of the room. I mean, I left. And that's not something I would do. If you had seen me and followed me to the other side of the hospital, where I ended up hiding for the next 2 hours in a meditation room, ironically, behind a chair in the corner, you might have seen that I was having an emotional reaction. But beyond that, and nobody did see me do that, when I came back to work the next day, when I carried on, this is kind of what you would have seen. If you even noticed the match strike to begin with, if you even noticed that there was an emotional reaction, you would have seen a guy who maybe seemed fine, maybe a little withdrawn, maybe a little quiet, maybe looked a little tired, but you wouldn't have known that anything was going on emotionally with me because I wasn't going to show you. What was happening was a brush fire emotionally. 0% contained, out of control, spiraling, spreading, emotional, self-conscious emotional brush fire. So as the fight or flight took me to that room, it eventually started dying down, and I had some cognitive resources to then ask the painful, awful question, what does this mean for you? Suddenly I was then thinking not about the immediate danger that I felt that I was in. I certainly wasn't really thinking much about the patient, which I'm not, proud to admit. It was then like, what are people thinking about me? People are judging, they're going to judge me. I'm incompetent, I'm unworthy, I'm not good enough, I hurt people, I'm not worthy of being trusted. Why in the world would anyone put me at the perineum with a vacuum in my hand? Why would they do that? And this was shape-shifting in terms of the way it altered how I saw and knew myself. In that moment, and then the days and maybe even weeks that followed, going from I was a pretty good learner. People eventually called me a golden child, which I don't recommend being. It's not a very fun person to be in a residency. And I had sort of built this mirage that at that moment felt like a mirage of trustworthiness and of achievement, and it was all false. Like now, here was the veneer gone, and here was who I really was. And it wasn't just me as, the doctor, but increasingly me as a caregiver, me as someone who's worthy of taking care of other people, of worthy of being in a position, in a hospital, and as a doctor. We worked with Hannah we gave her a subset of our data from a study on medical students I'll tell you about, and we said, visually depict a shame reaction for us. And it's a 4-panel series. I'm only going to show you 2 in this presentation, and I'll show you where the other ones are online. And this was the data, and this was me, right? We kind of worked with her on this and shaping it. But this was me in that meditation room, and me and everywhere I went in isolation thereafter. And it could be physical isolation or, sort of psychological isolation. I'm there, but I'm not there. And it's not that I'm just sitting there mindlessly. I'm sitting there and there's a churn, this really rough, self-flagellating rumination that's going on. Along with that, some skewing of my frame of reference, right? What I eventually did to move through this is that once I've kind of found the courage, I reached out to my best friend in the program, still my best friend today. And, we went to brunch. and he's a funny guy. And I trust him. And we were eating breakfast, and I tried to tell him the story. I finally was able to just tell someone what happened. And he was like, I just don't think I'm getting, what happened again? And I was like, all right, hang on. And I got a napkin, and I got a dinner roll, and I made a vagina in the napkin. And I was like, the head, it came through down here and not up here, right? And then delivered it through the napkin. And then at that moment, that was the first time I'd laughed. I was like, this is absurd. You watching from the other table, us do this. But what happened next, when I was able to explain what happened, is the first thing he said was, I know this must have been rough. This could have happened to anybody, right? You had only done one vacuum delivery before. Where was the obstetrician in this, right? Not to blame the obstetrician, but I needed support and guidance. I needed someone to walk me through the motions. Why didn't you ask for that help, right? You could have asked for help. You had been up for 24 hours. What about the baby? The baby was dying. How did the baby do? Oh, the baby lived. Well, it sounds like you might have saved the baby's life, in the process here. He was able to give me new ways of understanding this situation that were not about me, the incompetent doctor, but things that I did or didn't do that I could theoretically change thereafter. Now, I eventually came to understand this psychologically as a certain type of support that neither one of us knew he was doing at the time. But that ability to talk about this, unskew that frame of reference from it's all about bad me, which is a very self-centered perspective, to here are ways that I could improve and grow for the next time, was really transformative. It didn't make me feel good all of a sudden, but it made me open my mind to new ways of seeing and understanding myself so that I could work through the implications of this error. So it turns out that this was a shame reaction. And I, in reeling from this, also at the same time, I got out of a bad relationship, just not overtly bad, but just wasn't treated that great for a long time, and kind of came to blame that on myself. And, it's kind of a chronic sense of inadequacy in a relationship. Got out of that around the same time, and then just had to pick up the pieces of like, who are you? It was just crumbling. And after, I was telling people last night, I think untold number of hours, like in a baseball hat with my collar put up in the Barnes and Noble self-help section, just and some sort of yoga stuff. And I just was experimenting with anything, including a book called What to Say When You Talk to Yourself, which was sort of helpful. And then I was like, none of this is working. I came across Brene Brown's TED Talk on shame and vulnerability. And it was the first time ever that I had heard the word shame talked about so openly, authentically, accessibly. And it was like, this is exactly what I'm feeling. It was unbelievable, curtain lifting, fog clearing, and then I could see it better. And the way we define shame, and I'll mention my colleague Luna in a minute at the Shame Lab, and is an amalgamated definition. By no means is this the definition. There's so many ways to experience this emotion, but what they often have in common is this global sense of inadequacy, of being flawed or unworthy or deficient in a way that's not easily changeable. Okay, it's a stable thing. My intellect, my competence, my attention to detail, my looks, my attractiveness, how good I am or not. Okay, it's a global negative assessment of the self that often, if not always, according to some theorists and researchers, brings with it a painful sense of negative judgment from others. And I've really begun to work more with this part of the definition as I've been working with Luna Dolezal, who's my partner in the Shame Lab. She's a philosopher from the University of Exeter. And so she brings this awesome perspective that synergizes with mine. She really conceptualizes shame as the experience of negative judgment from others. And you could argue that feeling flawed or deficient or unworthy we often feel that way about ourselves as if it's through the eyes of another. So that could be someone sitting on the other side of the room that's watching me make this error and thinking that's a bad doctor. It also could be someone who could be there, a projection, someone that if they were over there looking at us would be thinking this about us. And the best example I've come up with of that, to understand that for myself, is that I have a 5- and 6-year-old boy / wild animals. And when I am out in the yard with them, having a blast. I mean, you know how kids are this age. They can go off a cliff pretty quick. And when they go off a cliff, they're hungry and they start, just being terrible. It's sometimes hard when you're feeling that way too, to not hold it in. And you just have a moment of frustration. Your tone's too harsh. You just act in a way that isn't in alignment with who you want to be as a dad or a parent or a loved one. In those moments, when I feel shame, which is a major trigger for me, it's as if there's a neighbor watching me. And I think there's a neighbor watching me and thinking that's a bad dad. Now, in reality, none of the houses around me have windows that look onto my yard. It's not possible for there to be a neighbor there. And if there was a neighbor there, they would probably be saying, God, that poor dad, right? Just a bunch of wild animals that, that nobody could control, much less this guy. That sometimes that perception of negative judgment is an assumption that we're making, but maybe isn't even actually true, right? That someone else looking at us is thinking something entirely differently. But we believe in our reality that it's a negative judgment of something about us globally that's deficient or flawed or unworthy. So when I came out of this fog and had shame as something I was understanding, and then also just getting kind of excited about because I thought, wow, this seems important in the work we're doing. I went back to my environment around me, started looking at interactions and relationships, different behaviors a little bit differently, my own experiences differently. Turns out I'm pretty shame prone, which is still working through that, and will never stop working through that. I also went into the literature, found an abundance of painful to read information about shame in psychology, but that has done a very nice job of making it a real construct. And then a dearth of information about shame in med ed and medicine. Barely anything about shame. It's wild. But lots and lots of signal for shame. You read the error literature, the remediation literature, the feedback literature. There's all sorts of signal that shame is here, but it's not being called that or explained that way. And that was really exciting and very overwhelming. And it's led to a heuristic that Luna and I have developed. And I don't know if we borrowed this from someone else or not. I'm pretty sure we didn't, but it's one that we're working with a lot. And it's this concept or notion of the present absence of this emotion. Okay, it's there. How could it not be? We feel shame as people because we evolved to feel it. This is not a random emotion that we fall into. Right? This is something that has really helped us evolutionarily as a species. Shame is very important in keeping us adherent as a group to standards that are important for societal functioning. Early days of human existence, if you got shamed and ostracized from a group, you got eaten by the mountain lion around the corner. That once cooperating as a group, and then also not to mention passing your genes along, the ability to pass them along often meant being in relationship. Shame was a way to tighten those bonds in that relationship in an evolutionarily productive way. And there's a whole body of evolutionary theory about that. And that's a really powerful notion that, because sometimes when you feel this emotion, you feel so bad for feeling it, and you feel like you're not supposed to feel it. And that is a dehumanizing perspective on this emotion. Okay? Shame is a normal human emotion that is very painful and that can be pathologized and very destructive even when it's serving some important social functions. It can also be weaponized, and I'll mention that in the end. So we are working, I think, within a present absence of shame in medicine and medical education. We think we're working with the present absence of shame in professional practice, law, policing, criminal justice, business, engineering. This is a salient experience across professions that is not getting addressed. Honestly, we would live in a present absence of shame in society. And there's too many examples of that to share and not get fired. So, all right, so to build this further with a metaphor that is extremely overused, it's the iceberg metaphor. It's too good not to mention, though, that I think our paradigm right now, one of the reasons that we're struggling so much to wrap our heads around why people are distressed, how to make them feel well, how to make them feel like they belong, is that we are stuck on important, critical constructs and elements of that experience that we can measure easily and talk about. Okay, and the principle of which is burnout. And that literature is phenomenal. It's been so well researched. But we're trying to explain much of our experiences with burned out or not, depressed or not, anxious or not, stressed or not, that we're not attending to the deeper, more fundamental human experiences that are hard to measure and hard to talk about. They're really hard. Shame is maybe the prototype of these experiences. And what's scary about this is that the depths of what that could contain might be ugly. It might be hard to deal with. It might be re-triggering, but we think it's transformational. Because if we don't go down there, if we don't acknowledge that that depth exists, we are dehumanizing ourselves in a humanizing profession. So in the act of trying to wrap my head around this as an early, emerging scholar, I suppose, I did a lot of theorizing and presenting, got some validation back from this being of interest in and then I don't know if folks know Lara Varpia. If you're in the education world, you probably know Lara. She's just an absolute force of nature. Such an amazing person and scholar. I had the incredible privilege to be mentored directly by her for many years. Still very good friends with. Lara brought me lovingly, insidiously to the deep edge of the deep end of the pool, backed up and then hip checked me into the pool and was like, you have to start researching this. Like, you can't just keep talking about this and theorizing it. And that was an intimidating foray too, as someone who had never really seen himself as a researcher. But with some amazing support, we then launched into a whole research program on shame. And we really wanted to ask this fundamental question, not presupposing that shame occurs in ways that have been described in other populations, quantitatively especially, but coming from a constructivist perspective, an inductive perspective of how the learners and healthcare medical learners experience this across the continuum of their education. And this took the form of 3 cross-sectional studies that were qualitative in nature, interview-based, each used an elicitation technique. Either they wrote a story or drew a picture of a time they felt shame, and then a really, really powerful, deep, and sort of emotionally probing interview that led to unbelievable richness of data. We used a method called hermeneutic phenomenology. If you're in the qualitative research space, even if you're not, this is such an amazing, powerful, pretty nerdy, research method. You can really get into the weeds with some of the philosophy that underlies it. But what it essentially does is it asks the researcher to provide a rich description of the nature of a phenomenon, in this case, shame, and to try and communicate its deeper meanings or essences, often which are difficult for any one person to describe. And that's often the case with shame, right? It's sometimes hard to bring up the deeper insights about our own shame when it's hard to connect with that in the first place by virtue of the emotion. So it does this through a few different methods. One of the ones that I find the most powerful, and I only tell you this because it's a little bit how I frame the next phase of this, is that it asks the researchers to attend to the relationship between the parts and the whole of that phenomenon, of that lived experience. So the structures, and then how does understanding of those structures and their relationships drive awareness and understanding of those deeper essences, the meanings, the things that make this what it is a unique phenomenon. So I'm going to walk you through a brief overview of the data, really brief. I've had to do this like 100 times to figure out how to compartmentalize it. I'm leaving so much out. So if nothing else, this is a preview to send you some of our papers. But these are the parts, the structures of that experience. So the first are just an example of some of the self-talk from our resident participants, and these were the students, about how they felt about themselves in light of the experiences we were talking about. And, across these descriptors are that definitional negative global assessment of the self: unlovable, unworthy, worthless, not good enough, a waste of space. Also, this is sad. This is distressing language to understand that students are using to describe themselves, and it's super common. It's really common. And sometimes it may be a little more insidious. I just don't know if I belong here, right? I just don't think I'm ever going to be good enough to meet the standards of this institution or what it wants me to be. This language comes up all the time. And it's often a powerful signal for shame if we're aware of what it could mean as an underlying emotion. We looked at how it originates, and then we have 3 papers on this across the data set. I'm just going to tell you the structures themselves, that critically we found that shame is an individually experienced phenomenon, okay? That it comes from a self-evaluation, and therefore it is uniquely individual. Some would argue, only I can feel the way I feel about myself, and only I can decide how I feel about myself. But really importantly, this was not just an individually experienced phenomenon. It was heavily contextually influenced. It was about the interaction between person and environment. And there's been whole, meta theories on what it means to be that look at person times environment. That was absolutely salient here. The environment could have a heavy influence. It might not ultimately dictate how I feel about myself, if only I can decide that, but it could very heavily influence it and make it very hard to feel any other way about myself than deficient or flawed or unworthy. And there are characteristics of those environments that we've explained and described. And we have a paper about to come out about shame engagement, how people healthfully and not healthfully engage with shame. And there's a whole section there about environments that facilitate or inhibit that healthy engagement. Okay, so there's a lot to be learned here about what those environments look like. We then identified shame triggers. So what were those events that caused people to feel this way about themselves? And we kind of grouped them across the data sets. One were very commonly related to patient care. This was especially true in residence. Hurting a patient, we had stories of of errors that caused deaths to patients, not showing empathy to patients, revealing emotion to patients, being mistreated by patients. So patient care was not surprisingly at all a strong trigger. There was another big bucket around shame related to learning. And this was really powerful and somewhat sobering information. You can slice this information in many ways. One way is that we found learning events that we considered as researchers, that most of us would consider to be normal learning events, like being wrong in public, getting below average on a test, struggling with a new task, receiving negative feedback, having to remediate. When you just look at what learning is and should be, frankly, those are just normal learning events. Maybe they're very painful, but the fact that so much shame was occurring during normal learning was notable. And then we found events related to learning that should not be a part of learning. Being humiliated, being questioned to the point of humiliation, i.e. pimping, for lack of a much better term, being peer derogation, being ignored, not being given a meaningful role in a team. These are all part and parcel of a learning experience that, not surprisingly, cause shame. And I'll tell you, some of the most profound shame came from mistreatment. There was one resident that was on a clinical rotation and was constantly marginalized throughout the experience. Nobody knew her name, nobody really acknowledged her, and they would get kind of annoyed when she presented for a long time. And she reflected. She said, the only way I could square this experience 3 weeks in is I started to think, is it possible that I am autistic and was misdiagnosed my whole life, and that's why everyone's treating me this way, right? Which, not an unreasonable thing to think. We misdiagnose autism all the time, but the only way she could make sense of that experience was to think that there must be something about me that has been missed all these years to explain the way I'm being treated. Okay, and so that's shame at its sort of most foundational. And then we also found shame related to personal goals and personal, who we are as people. And that bridges into the last structure, which is shame promoters. These were those individual characteristics, environmental factors, interpersonal dynamics that either predispose this, like an oil spill or a gas spill on the ground before the match strike, or were gas on a lit fire. And these were things like perfectionism, tendency to compare to others, fixed mindsets, psychologically unsafe learning environments, being underrepresented in an environment. Underrepresentation was a major driver of shame, particularly when, coming into a place and feeling underrepresented in the midst of struggle, mistreatment, marginalization. It just preyed upon that rooted feeling that I don't belong here, and that I'm the product of some special process that got me here, imposterism. I'll tell you, in doing this work and receiving stories and thinking about them deeply, and then reflecting on myself, I cannot relate to what it must be like to feel certain ways about myself because of who I am in a space. And I realize I've never had to worry about that because I've always been in the dominant group. As a white man, heterosexual, cisgender presenting, I've never been outside of the dominant norm. What I can understand is the amount of emotional privilege that gives me. What I don't have to navigate is a result of stigma and oppression and racism and all of its structured forms. I don't have to navigate certain emotional experiences that others do. And that, to me, is a form of emotional privilege. And one that I've had to figure out how to carry, and then how to do something so that privilege, that burden at least is a more equitable experience for all of us. Lastly, we looked at what does shame feel like. This is my favorite part of the data. And it really looks at the hardcore phenomenology. And I'll just show you one table. There's a lot of richness in this data, but I show you this table because this was sort of the amalgamated list of elemental parts of the shame experience across 16 med students that told us about this. So not every med student had all of these, but every single student had a set of these. And the reason I show this is that I think it first tells you how incredibly complex this emotional state is. I mean, it has a lot of different dimensions to it. But imagine if you're feeling any variety of these and you're trying to learn and you're trying to show up and you're trying to put forward an impression that you've got it all together. What sort of cognitive load and emotional load does that require? And what effects does that have on learning, on engagement, on receptivity to improve, to feedback, et cetera, right? So, I mean, I think not every shame reaction has all these, and not every shame reaction is shape-shifting. Sometimes one of our participants said it was like, it didn't shake the foundation. It was like a fleeting moment of shame. Other times it can be a more chronically experienced subset of these that really can pervade a deeper sense of self. Okay, there are a number of essences that come from this. Maybe one of the most fundamental that I think is important to convey came out after this second study, and it was really deeply sort of expanded in the third study in pre-med students, which is that shame tends to be, can be, and maybe to some degree is always, a destabilizing emotional state. And this can be destabilizing in an emotional sense, like me, disoriented, depersonalized, off my axis, sort of free-falling, and it can also be destabilization in terms of self-concept, how we know ourselves, who we know ourselves to be, and how we feel about that person. That those can be acutely or chronically destabilized. And that often prompts efforts to restabilize. Okay, and that our most recent paper is what those efforts look like. When people try to restabilize a destabilized self, what do we do? And what outcomes does it lead to? And I'll just, as a brief preview to that, it can lead to profound growth, new ways of understanding ourselves, strengthened self-concept, being brought back into community. And it can also lead to the deepening of shame. That the only way, or the repression of it, the only way to restabilize is to make this go away, or is to accept myself as just a deficient, unworthy person in this place. So a more shame integrating versus disintegrating process. And we think there's a lot to learn from what those two processes look like. It also layers on a number of existing psychological theories. This was a great quote of this destabilization. This is a student just in the beginning of his clinical year coming out of preclinical. He rocked it preclinically and all of the path up to there, and he was struggling clinically. And he said, I'm just in this weird tier of, I'm held up just enough from the drafts of my success from before, right? I don't feel like I'm plummeting, but eventually those drafts are going to go. And then what happens next? So this precarious state of I don't know who I am and how I'm going to do and whether I belong. One of the best quotes to explain this, and then also the skewed frame of reference before I move to the last part, and this was one of the most powerful, I thought. And this was a woman who, over the course of preparing for step one, really, really struggled and got below average, started to see her career just all her doors closing, because that's what step exams do or can do. And also this clash of the person she knew herself to be, which was high achieving, respected, seen as very smart. And then this free fall of all this new evidence that said that's not true. And she said, during this period of time, and she said, in fact, now, she said, if you point blank ask me, are you smart? She would say, I've been really well trained. I've worked hard. I've got a brain that works for me, and I've scored, and I've done really well academically. And I would be like, yes, I'm very smart. And I could say that confidently. And she said, but if you ask me, do you feel smart? She said the answer would be rarely. This tension, and not in an abnormal sense, maybe just in a real sense of what rationally we can say about ourselves and then what we feel about ourselves can often be held in this really powerful tension that can have major impacts on us, on our behaviors, on the ways we see and feel about ourselves. And what some of those can lead to are negative outcomes that we found related to shame. And they're pretty significant and they matter. And it's why we're talking about this. And they're a little bit sobering. Okay, this emotion has major impact on people. Not uniformly negative, okay, but it is absolutely having an impact in ways that might give us new ways of understanding some of these complex challenges. Now, what's powerful, and thank God for this, because in order to understand what to do about shame, you have to understand about shame. And that part of this is really hard. What's really empowering about this are all the ways that we can grow from this experience. Okay, this experience can be among the most powerful catalysts for growth and new ways of understanding ourselves. And these were outcomes that we found through more healthy, constructive shame engagement. And these are good, both for individuals and a functioning collective group of people. So the question that follows is, how do we take the existence of this emotion and learn about it in a way that helps us engage constructively with it. And that's the whole point of doing all this research. In fact, that's where we're spending most of our time now. I think we know enough about this to begin actually doing something about it. We see it as an imperative. We have to do this because people are feeling it and it's having negative effects. But more so, we see it as an opportunity that we can't miss. And another way that we've begun to conceptualize this that I just want to present is going beyond just thinking about shame as an emotion and understanding it to capturing and leveraging shame as a lens. When you start to understand this emotion and you start to understand where it comes from and that people feel it and that it has to do with how we evaluate ourselves, you can start seeing yourself, your interactions with others, others' behaviors, their responses to your behaviors, structures in your organization, our society. You start to see it differently. It's like having X-ray vision, and it really is kind of amazing. It doesn't make you a psychologist, and it doesn't make you someone that can always know how someone's feeling, but just the mere thought of the fact they could be feeling that way can be very transformative and empowering. So to operationalize this, we developed a framework we call shame competence, and we've described it and we've developed competencies around it. We're delivering training on it. And I'm going to define it for you and then tell you the basic principles and then stop for questions. We define this as a set of skills and principles and practices that can facilitate constructive engagement with shame. It's not a character trait. It's not something you need a therapist for. It's not something you either have or you don't. So you cannot be deficient in this in a bad way. This is a sufficiency model. Where is it? It's a non-deficiency model, okay? Everyone can and ideally should become a little more shame competent, okay? And along the way, if you develop resilience, great, but this is not shame resilience. These are skills, principles, and practices we can learn and that we can apply throughout our organization. So we really focus on shame at work, shame in professional practice. How can we take understanding of this, do our jobs differently, and serve the people we take care of better and attend to our own well-being and belonging in more authentic ways? Okay, so it has 5 pillars to it, and we structure training and understanding around these 5 pillars, and they build on one another. So the first pillar is to maintain awareness of shame. It's fundamental to everything else. This is Shame Competence 101. And frankly, if this is all you ever become competent in, that's fantastic. That's way better than we're doing now, which is general sort of obliviousness to this emotion for understandable reasons. Maintaining awareness means that we acknowledge the presence of shame or the potential presence of shame in the people, in the structures, and the experiences around us. It requires that we acknowledge that at any given moment, we and others are probably self-evaluating in some way, especially in these insecure, high-stakes learning experiences like medicine. How could it not evoke a self-evaluation? And that we attend to the fact that at any given moment, someone around us might be feeling shame. You don't know that they are, but if it's possible, and we care about that person, and that's the key part of the equation, then we should and we can interact with them differently. And one of the ways to operationalize this is just to think about how might they be feeling about themselves? How might this patient in front of me not be feeling? That's empathy. We think enhanced empathy is how might this person be feeling about themselves, their self, as I interact with them, as they navigate this healthcare system, as they go through a learning remediation. Okay, fundamentally, we operationalize this belief in the inherent worthiness of people and their need to feel valued and cared for and safe. That's really where this comes from. And if we can't instill this in a medical learning environment, where can we instill it in society? In medicine, in a medical learning environment. The second is to recognize shame. I'm not going to go through this, but there are some profiles of shame that we can learn, right? You can learn that if you hear certain words, if you see certain behaviors, if people describe certain things, that this could be a shame process, a shame reaction going on. Another sort of, I want to just make this point that often shame is sort of depicted and understood as this sort of isolating, making oneself small, disengaged, sort of meek, self-protective profile, and that definitely exists. We found in our data that this was from I drew this from one story of a guy who didn't become chief resident, had a massive crash that was like the biggest failure of his entire life. And then in the midst of being in a shame state the next day or the day after, cussed out his ER attending loudly when she gave him negative feedback, constructive feedback, cussed her out. He said, any program directors or APDs or faculty in here? She said, he stopped and he said, the program descended on me rapidly later that day. I was like, I can imagine what that was like for you. And he found himself on a brutal, really tough remediation process. half the interview was all about his defensiveness, about how he didn't take accountability. He was angry. It was all them attacking me. The shame came up the second half, right? And it's because what we were seeing as researchers, what the world around him was seeing, was not the shame. It was the behaviors that can be driven by shame, often in a desire to bypass it or repress it. So, and many of those behaviors are disruptive and challenging to deal with. I actually submitted this drawing to academic medicine with that first paper, and they said, "Oh, this is a great concept. We love it. Can you please pay a professional?" And so this is what we came up with, and now Hannah's made an even better version for us. I personally like this one better, but really gets to the heart of it. Yeah, but this is an important thing to remember, that sometimes the profile of shame is attacking other people, of being defensive and not accepting accountability. And before we react harshly to those, we need to attend to the underlying distress and possible shame that could be driving them. And that we do a lot of training around how to do that. The third pillar is to avoid inducing shame. And this acknowledges, we really strongly believe, and we know that shame, when induced on people, can drive behavior change. It often does. And sometimes those behaviors can look good and be good. But the degree of unnecessary, deep suffering that can come with that, and often does, often mitigates the real value of what's being learned, okay? Or it just doesn't seem necessary to begin with. The second is that shaming is an act of causing someone else to feel shame. In terms of its impacts, is what we call mercurial. You're working with mercury. You don't know how this person is going to take that and process it, right? Because it's a very unstable experience that people have. And coupled with that is, you probably will never know how they responded. They're not going to show you. So you might see a resident that's suddenly coming back and doing better at a certain skill. What you won't see is what's going on in that table, in the quiet room, in the recesses of their mind, about who they are and whether they belong. Okay, so while shaming, does change behavior, we feel very strongly and advocate very strongly that we stop using this as a pedagogical tool. And I'm going to argue, if you can't teach someone without shaming them, you shouldn't be teaching. Okay, now, I think much of the shaming that happens pedagogically is not intended, and we have different profiles of shaming we've defined, some of which are kind of on the mindless end of the spectrum, the accidental shaming. I think this is good for you. I'm just not missing the fact that it might not be. And then there are also types of behavior that really do reinforce hierarchy, put people in lower positions, and are meant to keep them there. And I think they all happen in medicine. What we need to do is we need to stop intentionally shaming people to make them better. And when we accidentally shame them, we need to recognize we've done that, and we need to repair. We need to apologize. And I think we grossly underutilize apology as a tool in the work that we do. Fourth, we proactively support people. We can learn how to provide this support once you recognize that shame is there, once you've acknowledged that it exists. These are some of the ways we do that. And there are ways to train ourselves and people to go through some of these basic things. Again, not making you a therapist, making you a better coach, a better mentor, a better supervisor or peer, okay, in very practical terms. And then finally, we can transform organizations. And this is the high level stuff that we really are trying to get our heads around now, is how do we take all that and create a shame competent institution? At Duke, we're doing a cross-departmental training pilot right now in family medicine to create the first shame competent department. So we're training faculty, are getting 6 to 9 hours of training. Residents are getting 8 hours of training. Executive leadership are getting 8 hours of additional training. Frontline clinical staff are getting trained. We want to know, can we create a place where this is how we do things? Okay, and that's in line with our mission of making shame competence a standard of professional practice. In the vision, to meet the vision of a shame competent world. Yeah. So we really advance organizational and cultural shame competence. We do that by establishing shame competent leadership, examining and modifying the structures that exist in our organizations that make people feel shame, and intended or known or otherwise. Where we advance training within and across departments, and then where we disseminate what we learn. This is not going to be a smooth ride initially, maybe ever. So we have to figure out what works and what doesn't. I'll leave you with this, the fourth panel from that series. And Hannah, this is where Hannah depicts really what looks like shame competence, what looks like, kindness and love and maybe emotionally sensitive practice, where we take our shared experiences of these emotions and we leverage them right? To build connection, to build belonging, community, to bring people back into the things that make them feel and make all of us feel worthy and good to be here doing the work we do. And I think this is what we're after, and this is the goal. So with that, I'll stop and take questions. Yes, please. And I think, yeah, got a microphone.
I'm wondering, because I know a lot of this is about the education of like medical students, but in terms of interaction with patients, because I think a lot of times when we're asking patients to make hard behavior change or lifestyle changes, that inherently sometimes approaches can come across as shaming like to the patient. So I'm just hoping you can talk about interactions between like how someone's own shame competence as a like when they're learning and how that can translate to those interactions for shame competence with patients.
Yeah, I mean, you can translate it to so many things, but certainly with patients. There's a small body of literature, very small relative to other bodies in what affects health outcomes, a very small body of literature around shame and patients. And how it manifests and what it causes, and it can undermine health outcomes. I mean, there's objective evidence of that, whether it's CD4 counts in HIV patients or metabolic syndrome measures, so on and so forth. One of the common ways that shame manifests within a patient care clinical encounter is I don't feel safe speaking up and sharing this concern I have. I'm not going to admit that I'm not taking my medications. I'm just not even going to come back and see you because I felt so bad about myself when I was in your exam room that I can't. And even worse, I'm not going back to the healthcare system until I absolutely have to. And we know how that ends up. So we actually did we worked with Impro, it's a malpractice provider up in New York, and we helped them build a 5-hour shame competence for the clinician online training series that essentially taught them all about shame and how to be more shame competent in their interactions with patients. And I did some live workshops with them for that, and I got some pushback. I mean, there were people out in the audience that were saying, how am I supposed to help people get better without shaming them? And they think, and it was usually related to some lifestyle choice. The common ones are obesity and smoking and substance abuse and unsafe sex practices, things that are stigmatized in society. And there's a real pervasive notion that this is necessary. Public health campaigns often try to do this, right? They try to wide-scale shame people. Some would argue that that's how we've gotten cigarette smoking to such low levels, but we're not looking at the individual level of that phenomenon, what it actually does with people and how it undermines trust. So all this say, everything we talked about today can be applied in that interaction in unique ways. And in that way, we start to understand our patients differently, why they behave the way they do, and how we might leverage some of that awareness to help them towards better health outcomes. Yeah. Here, and then someone over here had a question too next.
Hey, Will. Question for you about giving feedback to learners. As a program director, I have a lot of faculty that come to me with feedback about trainees. And I say, you need to give them feedback directly so they're not hearing it just from me. And I think people have given direct feedback and sometimes critical feedback, and people feel like they don't mean to shame someone, but they feel shameful of their actions. And sometimes attendings kind of stop short of giving, and then they're like, no, actually everything's okay. You know what I mean? And then comes back to me and it's like, yeah, I gave them the feedback. Of course, then when I go and give these trainees feedback, they're like, well, they never said that to me, because I think it comes to the point where people are sort of with critical feedback. How do we do that without shaming someone?
Yeah, I mean, we could go do a 3-hour workshop right now on this. And that's what it would take, frankly, to work through a lot of this stuff. This is one of the most rich areas for application of this is in the provision of feedback. I think we're getting into a feedback crisis. One of the things I hear a lot is among faculty and maybe more senior residents, I'm too scared to give anybody honest feedback because they're going to report me. They're going to see it as mistreatment, or I'm too scared to make them feel distressed, or I don't have time, and they don't. I live that reality too. So I think we need new ways of understanding how to deliver and then receive. Learners need to be trained to receive feedback too, in ways that lead to the outcome of improved performance. So all feedback always should be given with the intent to improve performance. That's number one filter. If you're telling somebody something that isn't meant to help them get better or likely to, that's not feedback. I don't know what you're doing, but it's not feedback if it's not intended to help them improve. Then we have to come to understandings about how and why certain delivery of feedback might get received in certain ways. If I tell you, I have a hard conversation about how you keep coming late to work, or you're making these sexist comments in the OR, I got to talk to you about that. If I tell you, stop being so unprofessional, versus this thing you're doing is unprofessional and unacceptable. I don't think you are unprofessional as a person, but what you're doing is unprofessional, and we don't tolerate it here. I mean, there is accountability to be had here, but when you say you're unprofessional, it's one of the common, it's where the racism thing goes south. People feel like they're being called racist versus recognizing we live in a racist society. The second you feel like you're being attacked or labeled as something, defenses go up, right? Or shame or some other feeling can come back. So we can be trained to be aware of our language that we use. We also need to be trained in looking for the signs of how this might be received. So I'll ask people, especially after a hard conversation, do you mind sharing a little bit about how you're feeling about yourself after all this? I know it's hard, right? And that gives them a chance to say, I'm okay. I feel okay about myself. I feel bad. Or they say, I feel really bad about myself. And then I got some work to do to make sure they understand, I'm not talking about you. Okay, and fundamental to that is we have to make sure learners know that we care about them when we give them feedback. And if you really care about someone, then you need to give them honest feedback, right? And they often know when you're not being honest. And that's worse, because we were talking this morning with some folks, the theater of our minds will say, why isn't he telling me how bad I stunk that case up? Is it because it's so bad he can't even tell me about it? Right? And then we've missed an opportunity for you to give me some honest input. And then my thought process runs away with itself. In so many words, this is an area where we can make real change and practical adoption of things like shame competence. I want to make sure I leave room for other questions. It's a great one. Comes up every session. Somebody here had a question. Oh, okay. Oh, somebody online.
I've got a couple, I think, relatively quick ones on Zoom, and then maybe we
Okay.
can go back in person. One person's just asking more about the research you did and the various settings in which it happened and how much is local versus universal. And then a second question about thanking you for this talk, which I share, and commenting on the ways they'd love to see integrated into the work about medical error, adverse event training, and there are ways in which that's happened, and like maybe that could happen more concretely at UVA. So if you could comment on those two things.
Real quick, please go if you need to. I know we're at time. We're getting close to it. It's totally okay. In terms of settings, well, keeping the institutions anonymous to keep people anonymous. They were all academic settings. One was a military setting, which maybe skewed the data a little bit. And then one was a group of medical students at a big private institution, kind of top 20 institution, if you will, by some destructive metric. And then the third was a master's in biomedical sciences, pre-baccalaureate or post-baccalaureate program for folks trying to get into medical school. Now, all of them were conducted in the United States. Almost all of the data, the scant data that exists outside of that is from sort of Western, Northern, global North communities. So that's something we've become more aware of lately, that really kind of the global South, Southeast Asian cultures are very underrepresented. And that we know that shame does have some cultural differences, sociocultural differences, and we need to be very careful not to generate predominant knowledge that lacks those perspectives. So we've been doing work on that. We have a grant in right now to do a mixed methods work with Duke's University in Singapore, as well as in the UK, and then here. On the shame space, which I recommend, we've worked with graphic artists to tell stories of shame. We got a Singaporean med student and a Singaporean artist to create a shame story, and it's very culturally rich. We actually published that in a paper recently. And we're always looking for new ways to collaborate with people globally. So context absolutely matters. That said, there are very likely and do seem to be some universal elements of shame that cross cultures. What we want to know is, we want to know the whole of it as much as we can. So we need to make room for that inclusion. And then the other is related to medical error. If feedback is a place to apply this, so is medical error remediation. Had an amazing meeting with MJ, who had to leave, and some folks this morning about integrating this in morbidity and mortality conferences. Can we make a shame competent morbidity and mortality conference? And not only do I think we can do that, but I think that can be a major driver of culture change because of the sort of the entrenched archetype of an M&M and how much it really reifies some cultural dynamics, often destructively. And then, but then when it comes to medical error, the study we've applied for a grant for is to study shame and medical error. And we developed this way to measure shame which is fraught. That was a hard few years doing that. And now we're going to try to look at the relationships between shame and medical error, recency of error, and then some of the behaviors that followed it and some of the outcomes. So rich for not only empiric work, but also applied work. And I think there's real ways to build this into peer support programs, debriefing procedures, risk management proceedings. All of those groups should be shame competent, given the high likelihood that it's going to walk into their office. If you do need to go, please, I will not be offended. And I'm glad to hang out for a little bit after we're done. Yeah.
A couple of things. The word shame and the connotations around the word shame, why that was the construct or the term that was used when there are so many others. And the second part of that is I just recently found myself watching St. Elsewhere. I don't know if you've ever seen that.
Heard of it. Yeah.
And then ER, and then The Pit. And if you have any thoughts about how things have changed related to the way we train residents and how that is projected in the media.
Yeah. I watched too much Bluey and Blippi. Do not recommend Blippi to get to watch actually real shows anymore. But okay, so I'm sorry, in the first question, why the word shame? The real question is that why not shame? Because the word itself is weighty, it's stigmatized, it's taboo, it feels icky. That red shame that was there, that surgical grand rounds, it's a taboo emotion. And in fact, I think the only way we start breaking that taboo is just making it more okay to just say the word, say it, and then say, I experienced this, or I'm able to experience it. So I think that's important. And all the time, I was telling someone this story, we get asked, we'd love for you to come and talk about this. And we send the information in the bio and they say, can you just take shame out of the title? And we're like, no, we can't, I'm sorry. I mean, that's been journal articles, presentations. One person running an elective somewhere was asked by the dean or some dean that said, you know, we got to change the title from an exploration of shame and learning to professionalism in learning. And they had to change it. That entrenches stigma around this emotion. So in the future, a pie in the sky future is we don't need any lens at all to see shame because we just are owning it and expressing it, you know, when it happens more authentically. In terms of how training has changed, I've only been doing this for 12 or 13 years. I was trained after duty hours, but before maybe the 24-hour rule. So I've been maybe in a bit of a transition. I do think training is different now. I think that there are more humanistic approaches to training. There's a long tail of shaming teaching that is still prevalent today because that's how folks were trained. And that was not right. And that should be repaired in some way, I think. I do also think that there are a new set of really hard expectations for current trainees. And I think we need to be careful about piling these on that says it's their fault that somehow they're beholden to duty hours and that they aren't in the hospital as long. And you still need to be just as good. Or I just think the average medical learner just holds such unrealistic expectations of themselves. And they often think that that's what is expected of them. And that's often not true, but sometimes it is. When you sit up and say, you are all the best and the brightest that medicine had to offer, as many people at Duke do or were doing, that the average person sitting out there is saying, am I? And can I be? Especially if I don't know how I got here in the first place, right? Or if I'm underrepresented, first generation, et cetera. So I think this is where the shame lens is helpful because it can help us understand some of these insidious factors and forces that not only allow us to make a more humanistic training environment, but one that's also more attuned to those more real emotional experiences that are happening. And that's where we meet sort of the realities and the mission that we all are set out to meet. Yeah, we got to go. Thank you so much. This is awesome.